So there is a consensus to estimate the volume of the micrometastasis in the sentinel node. This is done in the routine. And Caroline, I would like to ask you, what else needs to be reported if we are talking about micrometastases from sentinel nodes? Are you doing any reporting on molecular status, let's say BRAF mutational status? Are you doing some evaluations on tumor mutational burden and things like this? Is there any biomarkers which needs to be reported by the pathologist?
So for the clinic, we do BRAF mutation testing at even thick primary melanoma, but stage 3 definitely we do, especially.
I'd like to ask you one question immediately, because I think that's so important. If you have a tiny micrometastasis, which is 1 millimeter big, how are you doing the BRAF testing, or are you going back to the primary tumor?
We do both, and we do also the immunostaining, because if you have very few cells, it's a situation where you might miss it by the molecular biology, but you see it if it's a V600E with your immunostaining, which is a good and quite well standardized. Good. So we definitely do BRAF mutation, we search for BRAF mutation, but all the other things like tumor mutation burden or all CD8 and all the other things that we could do, PD-L1, we do it only in the research field. So it's not to help us to take care of the patient presently.
But Caroline, so for the immunostains, you can't detect V600K,
no,
right? You only,
no.
It's only just V600.
Yeah, yeah.
And,
you know what I envision? I think
yeah.
for the future, probably like in the breast cancer, it will be a lot of immunostaining, and for the negative, we'll go to the molecular biology for BRAF. Because it's not a problematic immunostaining. It's not like PD-L1 staining, for example, V600E mutation.
Can I make a comment on that?
Sure.
Because I wanted to reinforce something that you mentioned, because this is something that really has started coming up a lot in clinical practice, which is it really ought to be the case that it's reflexive testing. If a node is positive in a pathology department, they should send BRAF, and whether it's an antibody test or a molecular test. And the reason that I say that is that when the patients then eventually come to see us, if we don't have that information, well, then we cannot have the conversation. We can, in general, speak about it, but it becomes difficult when you desperately have multiple therapies that you can consider, and they have different pros and cons, if you don't know whether or not one of them is reasonable. So can't emphasize that enough, that that's a test that needs to be done right away so that subsequent decision-making can take place.
And if we don't have it in the lymph node, we should go back to the primary, because it's very rare that it's not consistent.
So, Mike, you are known as a biomarker expert. So, you know, are you going for any other marker in the routine, like PD-L1 testing? I think this is a hot topic discussed for metastatic melanoma, but in the adjuvant setting, it might be even hotter. So what's your opinion about this?
Yeah, no, at this point, there's a clear indication for doing the BRAF testing. And again, I agree with Caroline. The immunohistochemistry test, again, is very sensitive. If it's negative, you do need to do the full DNA-based testing. At this point, we do not utilize PD-L1 testing in stage 3 patients to guide our management at all. So we really are not doing that testing in the clinical setting. As Caroline said, a lot of research interest about whether this will impact our management in future years, but at this point, not a standard test we're doing clinically.
Yeah, I would agree completely with that. It's really a research tool at the present time, because if you look at the data from the adjuvant trials for immunotherapy, PD-L1 expression didn't really seem to have an impact on efficacy of these of the drugs.